Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and this is the third lecture in the series of three. The first two were on the etiology, the definition, the symptom signs, the diagnosis of cardiac failure, and the other one was on the treatment and the prognosis of cardiac failure. And I emphasize that cardiac failure is a fairly common condition with various etiologies, and a good understanding is very essential for the proper treatment. So I hope you are now ready to have this quiz. This is again a quiz, but it's kind of a revision, and I will be showing some questions, giving you some time to respond to them, and then I will show you the right answer. And then there will be some discussion also if required. Then we'll proceed further. So let's start the quiz. The first question is, which of the following is not the cardinal symptom of cardiac failure? Exertional dyspnea, paroxysmal nocturnal dyspnea, orthopnea, nocturia, and exertional chest pain. These terms are self-explanatory. Exertional dyspnea is the dyspnea which comes on exertion. Paroxysmal nocturnal dyspnea is a specific type of dyspnea which comes usually late at night when patient is lying flat and suddenly feels short of breath, has to get up, and when he sits up for a few minutes, then he gets relieved. Orthopnea is almost the same, but the symptom starts immediately patient lies flat. Nocturia is micturition at night, and exertional chest pain is of course self-explanatory. Which one is not the cardinal symptom of cardiac failure? I think this one is easy. Exertional chest pain. In fact, all other exertional dyspnea, paroxysmal nocturnal dyspnea, orthopnea, they are very typical symptoms of cardiac failure. If somebody has these symptoms, a very reliable clinical diagnosis of heart failure can be made. Nocturia, of course, there are other causes, prostate enlargement, but this is also one of the symptoms of heart failure. So let's now move to the next question. Which of the following is the classical sign of left ventricular failure? Now please note down we are talking about left ventricular failure in particular. Bilateral fine crepitations, engorged neck veins, pedal edema, generalized rhonchi, and bilateral reduced air entry. Which one of them, all these five listed signs, is very typical of cardiac failure, left ventricular failure? In fact, whenever I suspect cardiac failure on the basis of the symptoms shown earlier, I specifically look for this sign, and that is actually very important sign, very typical and very diagnostic. Which one is this? It is the bilateral fine crepitations. Because it is left ventricular failure, it would affect both lungs, and fine crepitations are those crepitations which are fine in character and are heard only during inspiration, and they typically indicate left ventricular failure if they're distributed in both basal sides. Engorged neck veins, pedal edema, they are signs of right heart failure. They can be expected in isolated right heart failure or congestive cardiac failure or pericardial disease. Generalized rhonchi, if somebody presents with dyspnea, presence of rhonchi would actually suggest a pulmonary disease, typically asthma or COPD. Bilateral reduced air entry again is a sign of maybe some other disease, emphysema, something like that, but not heart failure. So I think out of five options given here, bilateral fine crepitation will be the strongest classical sign of left ventricular failure. Which of the following is the single most sensitive tool for the diagnosis of cardiac failure? All may be important, but one single most sensitive tool for the diagnosis of cardiac failure. ECG, X-ray chest, PA view, echocardiography, NT-proBNP, and clinical examination. Which single, all are relevant, I must say, but which single tool is most helpful to make a diagnosis of cardiac failure? It is surely echocardiography. ECG never gives you the diagnosis of heart failure. It can actually tell you the cause of cardiac failure. XHS might show cardiomegaly only if it is chronic cardiac failure and significant cardiac failure. And NT-proBNP is of course a new test, but I don't think I will give uh, weightage to NT-proBNP as much as I will give to echocardiography. Wherever echocardiography is not possible, then maybe NT-proBNP will be helpful. Clinical examination is great tool, but it has got some limitations. Of course, we will start with the clinical examination, but if you want to confirm the diagnosis, I think echocardiography is great tool. It will tell you if patient has got reduced ejection fraction. It will actually give you the exact percentage of ejection fraction, and it will also tell you the cause of cardiac failure. It will tell you if it is dilated cardiomyopathy or ischemic cardiomyopathy, or there's valvular disease, or there's congenital heart disease. So everything you want to know about cardiac failure, echocardiography will tell you. So that is the answer. Traditionally, heart failure has been defined as a condition with reduced ejection fraction. And these days we abbreviate it like this: heart failure with reduced ejection fraction. Now we know there can be heart failure with preserved ejection fraction, and this is abbreviated as HFpEF. Now the question is, what is the cut point of ejection fraction between the two categories? Now, when do you say, is it heart failure with a reduced ejection fraction or heart failure with preserved ejection fraction? Normally, you know, the ejection fraction ranges from 50 to 70%, maybe a little more than 70%, depending upon one's age. So, what is the cut point? Is it 60%, 50%, 40%, 30%, or 20%? It's 40%. Although this parameter is arbitrarily defined, somebody having ejection fraction of 45, that is low, that is not normal, that is less than normal, but then that patient will be classified as heart failure with preserved ejection fraction. Somebody having ejection fraction of 30, that person would be classified as heart failure with reduced ejection fraction. So you need to know this cut point. What statement about the treatment of heart failure is not true? Out of these five statements, you have to find out which one is not true. Low dose beta blockers prolong life if used in patient with heart failure. Angiotensin converting enzyme inhibitors, ACEIs, reduce afterload. Angiotensin receptor blockers, ARBs, can be combined with diuretics. Angiotensin receptor neprilysin inhibitors, abbreviated as ARNI, can be combined with angiotensin converting enzyme inhibitors. Digitalis is not the first line drug. So out of these five statements, which one is not true? This one, angiotensin receptor neprilysin inhibitors, ARNI, cannot be combined with ACE inhibitors because both increase bradykinin level. Now, if that happens, it would increase the chances of angioedema. Angioedema is not only a very unpleasant complication, it could be actually serious. So you don't want your patient to develop this angioedema. So these two drugs are never combined. If somebody is already on ACE inhibitors and you want to switch over to ARNI, it is recommended that you give at least 48 hours period of the washout period, so that whatever ACE inhibitor is present in the body, that is excreted before you start ARNI. So this further emphasizes that ARNI cannot be combined and should not be combined with ACE inhibitors. Let's move on to the next question now. In acute pulmonary edema, which of the following drugs is most likely to provide the quickest symptomatic relief? If it is cardiac pulmonary edema, right? ARNI is a new class of drug, or is it angiotensin converting enzyme inhibitors, or is it ARB, or is it furosemide? These are, and then beta blockers. So these are 5 choices. Question is, in left ventricular failure, the severe form pulmonary edema, which of the following drugs is likely to provide the quickest relief? All are, I think, good, but furosemide clearly, because it's a loop diuretic. Patient with pulmonary edema, they need to have some fluid removed from their lungs immediately to get better. So in this situation, of course, furosemide is the most effective drug. Of course, all these drugs will be used in chronic cardiac failure, and in fact later on we would like to withdraw diuretics because diuretics tolerability becomes a problem. Once patient is out of this volume overload, then we try to reduce the dose of furosemide and maybe we discontinue. These drugs are continued. In the acute setting, in the setting of acute pulmonary edema, furosemide is, of course, I think, in my opinion, the most effective drug. Next quiz now. Which of the following neurohormonal changes does not typically occur in heart failure? If you remember, I showed you a slide where I showed you many neurohormonal changes which occur in heart failure. And the question is, which one is not true? Elevated catecholamine, elevated pro-BNP, elevated serum renin, and elevated CRP, and elevated aldosterone. Which one is not the typical feature of heart failure? It is elevated CRP. Elevated CRP is actually a sign of inflammation. So in heart failure, there isn't much inflammation, whereas all others are seen in patients with heart failure. Catecholamine is raised, pro-BNP is raised, renin is raised, and aldosterone is raised because RAS is activated. But in my opinion, CRP is no reason for CRP to raise unless there is some additional inflammatory condition. But since the question is related to the heart failure, I think this one would be regarded as incorrect statement. Next now, Digitalis may be indicated in which category of the patient with heart failure? Heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, right heart failure with atrial fibrillation, and heart failure with pulmonary hypertension. In which of these following categories Digitalis has some role to play? heart failure with atrial fibrillation. Uh, Digitalis used to be a very popular drug and used to be the first line of treatment of heart failure. But since we had better agents now, Digitalis is not the first line drug because it definitely relieves symptoms, but it does not prolong life. It does not have survival benefit, whereas other drugs like ACE inhibitors, ARBs, beta blockers, they prolong life in patients with heart failure. So they are preferred agents. Digitalis may be indicated in those patients who are very symptomatic and are refractory to the non-digitalis drugs, or the patient who is in heart failure and plus there is atrial fibrillation. So that is the patient where digitalis is used, and typically digitalis will be used in addition to the other agents. Next one now. Sublingual glyceryl trinitrate (GTN) can relieve the symptoms of heart failure. And what is its primary mechanism of action? It is basically the drug for angina, but it can also relieve the symptoms of heart failure if given sublingually. Now, what I'm asking is the mechanism of action of GTN. Venodilation, arterial vasodilation, coronary vasodilation, positive inotropic effect, positive chronotropic effect. So which one is it? Which one is true? When this drug was introduced, it was thought that this is coronary vasodilated. It perhaps does have some coronary vasodilation. But what about others? What is the primary action of glyceryl trinitrate? So it is venodilator because most of our total blood volume is on the venous side. If taken sublingually, it will be absorbed immediately and it was venodilatation. So more blood will stay in on the venous side, less will come to the heart, and that will offload the heart, and patient's symptoms of heart failure will be relieved immediately. Of course, this is an immediate effect because after a few hours, the effect of nitrates will be gone and patient will again go back to into heart failure if something else is not done. High cardiac output failure is associated with which of the following conditions? You know, most cardiac failures are low cardiac output, like ischemic heart disease, cardiomyopathies, hypertensive heart failure. There's usually low cardiac output, but there is a category called high cardiac output failure. Now you have to pick up that one. Ischemic heart disease, hypertrophic obstructive cardiomyopathy, abbreviated as HOCM, hypertension, hyperthyroidism, and aortic stenosis. All these conditions can cause heart failure. Now, which one is typically associated with high cardiac output failure of these five? Hyperthyroidism. Actually, the concept of high cardiac output failure is that it is though higher than the normal cardiac output, but it is still less than what was required under those circumstances. Patient with hyperthyroidism, they have uh, with very dynamic heart, stroke volume is increased, heart rate is increased, cardiac output is increased. So if heart fails at a specific point, cardiac output may still be more than normal, but it would be less than what was actually required of that condition if the heart was absolutely normal. So hyperthyroidism is such condition where there could be a heart failure with increased cardiac output. There are many other conditions also, but out of the listed one, hyperthyroidism is the only one. Which of the following is not a radiologic feature of heart failure? Whenever we suspect heart failure, usually we do X-ray chest, and X-ray chest gives us very, very good clue. Now, the question is which one of the following is not a radiological feature? Cardiomegaly, bilateral pulmonary infiltrates, bat wing infiltrates to be more precise, bilateral pleural effusions, unilateral large pleural effusion, and Curley B lines. Which one of these five features is not a sign of heart failure? This should be easy, I think. Unilateral large pleural effusion. Cardiomegaly, of course, whenever there's cardiac failure, there's cardiomegaly. Bilateral pulmonary infiltrate is a classical feature of pulmonary edema. Bilateral pleural effusion, if the condition advances, cardiac failure typically causes bilateral pleural effusion. Right-sided pleural effusion is usually bigger, so there may be a time when you can see pleural effusion only on the right side, but then that would be small. If there is unilateral pleural effusion, and if it is large one, it definitely suggests some non-cardiac cause. It could be tuberculosis, it could be malignancy, it could be pneumonia, it could be some other thing, but not heart failure. In heart failure, you typically have bilateral pleural effusion, and if it is unilateral, that will be on the right side and small. A large unilateral pleural effusion clearly suggests an alternate diagnosis. Thank you very much. So this was Professor Aziz-ur-Rehman from Medurstand. I hope you like this quiz. So very soon I will be releasing some more videos on some other topics. I am really looking forward to see you there. Thank you very much.